네, 안녕하세요. 서산두리치과 박종현입니다.
Hello, I'm Dr. Park Jong-yoon from Sosanduri Dental Office. Today, I'm going to talk about the full arch implant occlusion. I believe it should not be very different from lateral teeth occlusion. However, implants are vulnerable to lateral force, so group function should be provided based on mutually protected occlusion. Let's have a look at basic principles of occlusal adjustment. Briefly, theories. In the past, in the 1920s, a school of scholars argued for balanced occlusion, but later PMS scholars did not agree to it, so it evolved to canine guidance. Over time, they evolved to mutually protected occlusion and group function occlusion without much differences between different schools. Let's look at the basic principles of occlusal adjustment that I use one at a time. First, maximum intercuspation adjustment to distribute the occlusal stress as much as possible. Second, as much as occlusal force should be applied along the long axis of teeth. Third, we learned this a lot in a dental school. This can be confusing, but after the lecture, please carefully look at this in slow mode. For lateral occlusion, non-working side occlusal interferences should be removed. If you don't understand the picture, just memorize it. Non-working side occlusal interference occurs on the inner side of functional cusp. Most important take-home message is to remove all the occlusal interferences on the inside of the functional cusps. Let me emphasize one more time. This is the non-working side occlusal interference. This is the inner side of functional cusps. Interferences on the inner side of upper palatal cusp and lower buccal cusp need to be removed. That is the non-working side occlusal interferences. Working side occlusal interferences are a little bit easier to understand. The interferences to the working side movements on the maxillary buccal cusp and mandibular lingual cusp need to be removed. Show you one more time. On the working side, interferences on the upper buccal cusp and lower lingual cusp need to be removed. One more time, I want to emphasize functional causeway internal oblique interference in the posterior region should be removed. I repeat that. At MI, occlusal force should be distributed evenly to the posterior teeth. This is a simple matter that everyone knows. Implant is strong to vertical force, so in the posterior area, the occlusal force should be distributed to withstand the vertical force. Anterior teeth have their own role to play. For anterior guidance, anterior teeth should exclude the posterior teeth. Implants are vulnerable to lateral force. However, the anterior teeth, not much affected by lateral force, should be able to exclude posterior teeth. Many people say the lateral force applied to the implant is harmful. And they say because of screw loosening possibility under lateral force, so the cusps need to be flattened. There should be about 1.5 millimeter flat area between central fossa, which I agree. Summary. When MI occlusion is formed, MI occlusal points should not be deleted. First, MI should be adjusted. After that, we need to mark lateral occlusion. After adjusting MI points can be deleted. Lateral movement is marked black and MI occlusion is marked red again. After that, the lateral interference can be removed. leaving MI intact. More clinical case. MI is adjusted. In this case, lateral occlusion should be marked first because MI points on the articulation paper can be erased during lateral movement. It is important to keep the MI points. After MI adjustment, a patient stands up and brushes his teeth, and then lateral occlusion is marked first, followed by MI point marking again. It is very important to keep the points indicated by red arrows. So I'm showing you the working side movement where anterior teeth is discluding the posterior teeth. So the concept here is that anterior teeth protect the posterior teeth, and for the vertical movement, the vertical force, posterior teeth protect the anterior teeth. Let's look at occlusal adjustments done in edentulous patients. Number 13. It was treated by me in 2014. I didn't do the endo treatment appropriately. It was restored again with a zirconia crown. To save the periodontally unstable number 13 natural tooth, occlusal treatment began. Frontal photo. At the beginning, abutments were made supramargin. After a year, gingiva went up, maybe due to hypertension drug. Now, please pay attention to this. Number 13, periodontally unstable, but I did not do endo treatment very well, so the apical lesion is also unstable. So it is not right to make number 13 alone to withstand the lateral movement. Early lateral movement, as you go toward 13, 14, and 15, the lateral force was designed to be decreased, but it was adjusted that they are all involved. Last period of lateral movement, the distal number 15 is not included. To protect number 13, 14 is adjusted to be involved in the lateral movement. Now, do you understand group function? I prefer to use the group function where the whole group is involved at the beginning of the movement, but the most distal tooth is excluded later. Kind of gradation. I had this problem because of mindless placement of an implant. Number 24, cantilever, and I tried to exclude it in occlusion. Number 13 has a long crown. Rather than making number 23 do all the lateral movement, it was designed that all 4 teeth are involved in the lateral movement at the beginning, but the distal teeth would be less involved in the movement. So I want you to concentrate on this area. Number 24, as I said before, is cantilever. So I didn't want the cantilever would be involved in the lateral movement a lot, so I concentrated the lateral movement on number 23 at the later period of the movement. So at the beginning, it was included in the group function, but later it was excluded. If it were not cantilever, it would have been involved in the lateral movement all the way. Now, do you understand the approach? When you do lateral movement, we include the teeth in the group function, but if something is not very good, it is excluded. At MI, the occlusal force is designed to be distributed evenly to multiple teeth. 4-year recall photos. 7-year recall. Number 13 was lost and replaced by an implant. Another case, case 2. All upper teeth need to be extracted. Number 13 severe bone loss due to periodicity, so we decided to do delayed placement. They were immediately loaded and we moved to the final prosthesis, and an implant was placed later at number 13. Look at here, number 13, it was a single tooth restoration. Number 23, bridge restoration. In this case, I approach it differently in terms of occlusion. Single restoration is not for canine guidance, but if implants are connected with a bridge, they can be used for canine guidance. Now, let's look at single restoration. Number 13, implant. It was designed to be in the guide with the lateral tooth and premolar. So lateral force is not concentrated on number 13 alone. The occlusion designed for the bridge at quadrant 2 without cantilever was canine guidance. Group function occlusion seems safer, but actually canine guidance makes the occlusal adjustments easy. It makes the surgeon more comfortable because it reduces the chair time considerably for occlusal adjustments. So prosthesis connected with the bridge, I use canine guidance. Take-home message here is that the canine, when it is a single restoration, should not be designed to get all lateral force. This is a regrettable case. Looking back, the cases that I showed today for full arch restoration, I always feel some regrets. If I go back to the time, I believe I can do better. Let's have a look at it anyway. It is regrettable because at number 13, I should have placed an implant there, but I made a cantilever pontic at number 13. So that created a problem for making occlusion for this patient. On the left, occlusion was provided as canine guidance without a problem. The problem was on the right side. On the right side, a cantilever prosthesis was made for canines, so group function should be carefully designed. My apologies. In the past, I didn't really use gloves when I did the treatment before COVID-19, so it was not strictly against the Infection Control Act. The patient could move the teeth laterally. The temporary was used for about a month, during which some interference must have been removed, but still, if there is more interferences in the posterior region than the anterior or premolar area, that should be removed. That is removing the working side occlusal interferences. After the removal, the patient could move laterally in a more comfortable way. When a patient cannot make the lateral movement naturally, it doesn't mean the patient is not cooperative. Maybe there's some big interferences. That's something you need to suspect. When a patient cannot make natural movements, it doesn't mean the patient is not cooperative. You can suspect if there is interferences. You understand, this is a photo after removing the working side interferences, the inner slope of upper buccal cusp. Based on the temporary information on the articulator, the amount of disclusion is adjusted. The group function prosthesis was fabricated. First, you need to check other teeth whether they are in occlusion. The fabricated prosthesis is moved from the articulator to the mouth. The video was made a long time ago, and I used the term CO, which is replaced by the term MI. The anterior region is in occlusion properly. This is a nervous moment when the prosthesis is delivered. If the opposing teeth are not in occlusion, we feel really bad. But everybody worked hard, including the lab, so everything was okay. As long as the delivered prosthesis doesn't have low occlusion, not much adjustment is necessary. You can save a lot of time if you do not have to adjust MI a lot. I think the lab can adjust up to MI. Now MI is okay and lateral occlusion is checked. The patient cannot move well. It seems a thin articulating paper cannot mark very well. So I tend to use a thicker articulating paper recently. Interferences are removed. Even if semi-adjustable articulator was used, you always have some lateral movement adjustment that you need to do. For group function, remove the interference on the posterior side as much as possible. Now, let's look at lateral movement. He cannot move really well, and there's some clicking sound, and the patient feels the interference. What about the other side? The canine guidance is made and it moves very well. So when a patient cannot make the movement, you need to suspect the interferences and you need to do adjustment. And if the patient feels more comfortable and moves more naturally, the adjustment is done pretty well. So at least the goal should be disclusion. Final MI rather than CO. The term CO should be replaced by MI. And they're in pretty good occlusion. Anterior region restoration. Before restoration, in this situation with the temporary, anterior guidance table needs to be copied. On the table, the temporary information is copied. Anterior guidance table will be explained in the hands-on training course. The last step, using the customized anterior guidance table, final prosthesis is fabricated. The prosthesis fabricated based on anterior guide is moved to see whether posterior region is discluded. Now right side prosthesis is completed with group function occlusion. It was not easy to completely exclude number 3 from lateral force. Luckily, in this patient, the number 43 was not functioning properly. So the 2 teeth, number 4 and 5, were involved in lateral force. Left side prosthesis was restored with canine guidance without cantilever. Now MI is marked. Final prosthesis is completed. Occlusal adjustment was done every week for 4 weeks. For full mouth rehabilitation until occlusion is stabilized, it takes time and continuous adjustment is required. I'm not happy about the canine cantilever. However, after 7 years, still the prosthesis is maintained, and if I can go back to the past, I would definitely place an implant in the canine area. Now, this is the last case. The final prosthesis was completed. Up to here, it is similar to previous cases. Ossification of bone graft in the sinus area is not very good, but it is still maintained. It is important to recognize that when a patient cannot make lateral movement very well, it is not that patient is not cooperating, but because of interferences. So this point of interference was removed and the patient could move very comfortably. So try not to rely on the articulation paper for everything. You need to observe with eyes and listen the sounds. for adjustment. There's no problem with MI, but the patient cannot move laterally. Actually, the patient was very cooperative. After removing the interferences, he could move very naturally and comfortably. At MI, occlusal force should be distributed. For periodontally unstable tooth or single canine restoration, group function should be provided at the beginning, but later the distal tooth needs to be excluded from the lateral occlusion. If canine is splinted implant prosthesis, I provide canine guidance for occlusion, as it is easy to provide occlusion or occlusal adjustment. Recall panorama X-ray. After 4 years, fortunately, the unstable teeth number 23 and 24 are maintained and works for lateral force. In this hour, we talked about occlusal adjustment for full mouth fixed implant restoration. For this, you need to understand the mutually protected occlusion. So with that concept, I moved to the final prosthesis. Based on what you learned, I believe you will gain good outcome from the occlusal adjustment, and I'll come back next time. Thank you very much for your attention.